So today our topic is the cervical cancer. Here the thing, very very important thing is that sometimes they will not give you the exact diagnosis that this is the cervical cancer or whatever it is, and when they are talking to you about this thing, they will give you just a scenario. So you are the one who has to understand what they want from you. Okay, one thing they will give you, and sometime when you are talking about any cancer, they will ask you, and in between the cancer they will ask you any type of cancer, any type of the cancer they will stage. But most commonly they will do in the endometrial hyperplasia. When they are talking about the endometrial hyperplasia, because this is very love question, this is very lovable question for the RCPI, na, this endometrial hyperplasia. So when they are talking about, when you are talking about the endometrial hyperplasia, they can go to the endometrial cancer. Here, when you are talking about the pap smear, sometimes they say, okay, it is abnormal, came sin 1, sin 2, sin 3. So in between that, they can ask from you the cervical cancer. I hope it is clear for you people. Okay, now we'll start our own question for today. Today our question is that she is a 25 years old lady, and she has been referred to the colposcopy clinic. Okay, referred to the colposcopy clinic with a cervical screening dyschirosis and whatever you think it that. She is a nulliparous and has not experienced any symptom. Because she is not having any symptom, but because of the colposcopy clinic, they found it that she is having a severe dyschirosis or abnormal cells, okay, on colposcopy, which they take the sample. So she is having no complaint, she did not have any complaint. So the thing is that sorry, if you want to say anything, no problem, doctor, you can open the mic and say it. So she has no significant family history and she was a known smoker. Okay, ji, this is the thing which we have it. Now, what is the thing he is asking? What are the chances of finding pre-invasive changes in a woman with a high-grade cytology? So this is the dyschirosis is a high-grade cytology. Okay, so we have two things here. The question he is going to ask from us, he is asking, he's going to ask us that what are the chances of pre-invasive changes. So and then middle of that one he will ask you the cervical cancer. So pre-invasive changes means he want to know about the sin 1, 2 and 3. Okay, right now high grade cytology, he wants to know that question. This is one of this question also. And another question is that he want to know about the cervical cancer. Doctor, I am clear so far? Okay, now we will go about the thing, because see here the thing is that the patient present without any complaints. So what we have to go about the thing, he asked about the management. Okay, how we are going to manage about our, we will concentrate first about the cervical cancer, and we have a also the presentation about the sin here right now, because they given for the dyschirosis. So we will go for the cervical cancer first, then we will go for the sin 3 also, sin 1, 2, 3. Okay, so for if she will present now, here he says she has no complaint, but if they can say it, that maybe she is having a PV bleeding, mild PV bleeding or spotting, and most spotting is after the means not related with periods. Sometimes they will give you like this question. Okay, so this PV bleeding is not related with her menses. She can have a PV bleeding anytime between periods. So this is the thing which they give it. So it means how you will manage it. So in our hand we have a PV bleeding. Okay, in our hand we have a PV bleeding in our hand, which we get it the symptoms. Okay, so right now which we have to ask about the PV bleeding. Okay, we'll start about the sin and this thing, but first we will start because she give us the thing that she has a PV bleeding. It is not related with menses, or she has a PV bleeding between periods, means not related with the periods, and she can have a PV bleeding after the menopause, in reproductive age, or it can be a menopausal woman. This is the first question we are going to ask. Then we will ask her, do you have any intermenstrual bleeding? Okay, because we have to, intermenstrual bleeding means we are excluding that she can have a endometrial cancer right now with this thing. And then when she is meeting with her partner, did she is having at that time bleeding? This is also another question. And please, we have to remember one word about the cervical cancer, because if you will see my, because this is my slides of my paid course. If you will look my slides, there is a blue, sorry, yellow marking. I done that one. This is means these are the golden points. These are the golden points which we have to remember for that particular topic. We are not supposed to forget this thing. We are not supposed to forget about this thing when we are asking the history. Intermenstrual bleeding, pelvic pain, pain during meeting with her. This is not so much important, but the most important thing is that she has a bleeding. Okay, when meeting after the partner, and she can have a change of her vaginal discharge. This is also another golden point. These 2 points you are not supposed to miss it in the history. Why we are talking about the vaginal discharge? Because sometimes she don't have a bleeding. So if she don't have a bleeding, what she will have it? She will have a vaginal discharge, but it will be abnormal, the foul smelling discharge, or sometimes it is mixed with brownish color. This is the important thing which we will ask from the patient. And sometimes she will come with the heavy periods, or which the periods last longer. So these are the complaints which we are supposed to know from the patient. We have only 10 minutes, doctor. In this 10 minutes, the 4 minute we have to take the history. So quickly, this is in the table form. I make it there. So if you want to be here, or if you want to remember from here, this is upon your choice. Okay. Then the hair, because we are concentrating here that maybe it is a what we call it, cancer. Okay, so in the cancer, always we have to ask the associated symptom. So please remember, with every cancer you have to ask this associated symptoms. In everywhere you have to ask what: loss of appetite, loss of weight. Okay, this is the one: loss of appetite and loss of weight. Must. Then we can ask, because if the cancer is spreading, what she will get it? She will get it the cough. If she will get, because if it is affecting the lungs, and when it is affecting the lungs, she can have a hemoptysis, blood in the cough. Okay, and she can have a pain and the thigh pain. Why we are talking about the pain? Because the pain is most because it is pressing the nerves, or it is damaging the nerves if it is cancer is spreading. So these are the things we have to ask it from her. And the leg edema, because edema how edema will come it? Edema always come because there is a lymphatic will start to be invaded by this cancer. Okay, so this will make it. So what we have it here, important points, what we get it here: the history about the vaginal bleeding, vaginal discharge, and the associated symptoms. Little we have to ask, no need to go in detail more than that one. Okay, you understand, doctor? Clear for you, Dr. Ayat? It's okay for you? Can I continue?
Yes. No, yeah, clear. Yes.
You understand. So afterwards,
Yes.
here before, when we will go it, so we will ask about the gynae history. We have to ask it. Gynae history, what we are going to ask it? In the gynae history, mostly we are asking about when she is having a last menstrual period, because she is here, she is only 25 years. Okay, so we have to ask about the last menstrual period. We have to ask about contraception. And here the most important point here about the pap smear, because 25 years of age they start to get the pap smear. Okay, invitation for the pap smear. So we will ask her, did she done the pap smear, or she has an invitation of the pap smear? This is the important point which we have it here. Okay, if she is less than 25 years of age, then we have to ask about the vaccination. Clear? So this is the points are very important points for the gynae points. Then we have to ask, if she is 25, we have to ask about the obstetrical history. In that family, she has any problem, any cancer history, because this is not related with the Lynch syndrome. Lynch syndrome is ovarian, colon, and the endometrial cancer. Here it is not related. The cervical cancer is not related, but we have to ask the cervical cancer in the family. And here the most important point here, in the cervical cancer, before they are telling, in the cervical cancer there is no relation of the genetics. Okay, genetics means with the family. In the family she can have a cervical cancer. Previously they say no, There is no relation, but newly I'm talking about new things they are making it. There is a relation, genetic relation. Okay, there is a genetic relation, and from downward here, this genetic relation. Okay, so we have to ask that in this genetic relation. 1 minute, I have written it or not. This genetic relation, because there is a particular about this thing, genetic one. 1 second. No, I did not write the thing about the genetic, main genetic. I did not write it here, but there is a genetic relation. Finish. No need to go it about that thing. That's why we have to ask about the family history. Okay, ji. So we have to ask about the family history. We ask it. Then we have to ask about the support at home. Any surgery she has. Support at home means what? Her uh, what her partner is cooperative or not. The most important other point is that because she is 25 years of age, my brother, my sisters, my friends, she is 25 years. We have to ask about what's her fertility wish. Why we are asking about the fertility wish? Because when we are doing the staging of the cancer, at that time fertility wishes are very important. What treatment we have to do? That's why it is related that it is dyscarasis. So what treatment we can do about which stage of the cancer? That's why the age is very important here. Okay, so we done up to here. So what we'll do it our then the here, because she is not having any cancer, diagnosed cancer, so mental history here is right now is not important. Okay, so we finish the history. If it is clear for you, doctor, or you want to repeat my this history, what you think you have to add more? Doctor, can you hear me?
Yeah, yeah, I'm hearing. No, it's clear. Okay.
So what do you think you have to add anything?
No, I think it's enough.
Okay. So afterwards, what we have to do the examination. Examination, please fix examination. We have. I'm not talking because for my paid courses, I have a different way to tell them. So the examination, what we have to ask, what we have to ask her the vital sign, her BMI. BMI is very important because maybe she will go for section. Oh, sorry, not section, for operation. Okay, so that's why BMI is very important for us. Then we have to examine her head to toe examination. Why we do the head to toe exam? Because she see her eyes. In her eyes, maybe she is having the anemia. Maybe she is having a because the cancer maybe is spread too much. That's why we have to exclude all these things. Maybe she is having other problem on her face. Here she covered the face, but the reason because she is doing here the colposcopy. Please, we have to I have to tell you one thing about the colposcopy. When we'll do the investigation, I will tell you here. Okay, so we done that one. Our thing is finished. Head to toe examination. Then we will come the examination per abdomen examination. We have to find any mass tenderness, rebound tenderness. We will not get anything from there. Here the in the cervical cancer, the most important investigation is the speculum examination. Okay, the speculum examination we will start. We will not do directly speculum. First we have to do the inspection of the outer areas. Okay, so when we will finish that one, then we will do the speculum examination. And the speculum examination, what we have to do, we look for the vulva, vagina, and then the cervix. Cervix we have to look the cervix. What we are looking, any abnormal changes in the cervix, isn't it? And if there is any discharge, we will take the swab, any swab there, it is there. So we finish our these things about that things, means bimanual examination. Then we have to do the bimanual examination after that one. Because why we will do that? Because we have to check, because if the cancer is spread, the uterus will be enlarged. Okay, and maybe it is making the problem for the furnaces, furnaces means it's spread to the furnaces also. So we have to check about the furnaces also. Maybe it is painful there. So here the one other thing is here, where there this cancer will sometime rectovaginal examination will do. In the rectum, we have to also assist her, because if it is spread to the vagina, from the vagina it can go to the rectum also. So we here the rectovaginal examination is important. Okay, the important thing here which I want to tell you about the colposcopy. colposcopy, we will do the punch biopsy. When we are doing it, we will do the punch biopsy. Here the one thing we have to understand, the colposcopy, there is see, that's why I put this picture here. What she is doing, she is doing the colposcopy, but if you notice it, there is something like a computer, something is in front of her, there is also a screen is there. So this is called the digital colposcopy. Now they are using this one. The one which we are using in that normally, they are not using nowadays. They put this one. Even this is in the clinic. This is a clinic, okay? This is clinic on the clinic based procedure, and there is a room in the clinic. They can put that one, and this procedure they can do it in the clinic. This is called the digital. Why we have to? Because examiner sometime will ask you, or he will tell you, okay, you are doing the colposcopy, can you tell me what type of colposcopy we will do? Normal routine, the one which we are using, it is standard one, but the best standard technique is the digital colposcopy. So what they are going it, they will put the procedure the same, which we put the speculum, and then bivalve speculum, then we will make that, we will put this some solution on that area. See, this is like that one here, it is like that area. So they will put the solution here, and this is the one, there is a digital mapping will come, the map will come here. It is like a map. This is the one, means the computer is the one who is going to tell us which area we are supposed to take the biopsy. This is because that colposcopy is dependent upon the patient. This is depend upon, sorry, the doctor experience. He can miss that area, where is the cancer is there on the cervix is there. So with that, digitally we can make it. If she will make it the digital one, the computer is the one who is going to tell you where the abnormal area is there. So this is the particular one, and see, the picture is very beautiful picture. So she will do that colposcopy digitally. So this is the exam question they can ask you. It's clear for you, doctor? Anything you want to know? Hello? No, nothing. Okay. Then afterward, because this will come in one of the investigations. So this is one which we do
One
it.
which we do. Yeah, it's clear, doctor. Clear, thanks.
Okay. So
Okay. So
we will do to her, what we are going to do, we'll do the examination under anesthesia, because this is the different cancer depends upon the categorization. Like the endometrial cancer, this is a surgical staging. Here it is a clinical staging. Okay, for that clinical staging, what they will do, clinical means you are the one who has to diagnose that one, and then you have to do the examination under anesthesia. But now they are getting away from that one, cervical cancer. They are coming to the examination under anesthesia, and they will do the colposcopy. What they will do, the punch biopsy. Sometimes they will make it some this digital one. Digital is the best colposcopy which they are using now in the clinic. Okay. So what we will do, the examination under anesthesia, this is very helpful for us. So blood investigation we will do. We do the CT, MRI, and here the PT-CT we do only if there is a recurrent cancer is there. Mostly we don't do until that previously she has a recurrence. Now the recurrent cancer came. So PT-CT we do at that time, but here we do the CT, MRI, and the ultrasound. Ultrasound is also very important here as the investigation. Now the question is that we will finish our thing here, because she is 25 years old lady and she want the fertility. Her wishes is that she want the fertility. Okay, we do the fertility. What we will do it? First we will go for the our this cervical cancer, this what we call it, classification. For my point of view, this is a very horrible cervical cancer classification. People, it's not an easy job to remember that one 10 times. If I am the one, I will do 10 times. Even that I will not remember what they are talking it. So for us, for my point of view, to remember the stage 1, because they will ask in stage 1, because she is asking fertility. So stage 1 we have to remember. Okay. And then what we have to remember, because she's going to make the hydronephrosis in this one, this is the problem that kidney will be non-functioning. So these two cancer classification we have to remember by heart. Others no problem, we will remember or not to remember. But my way is that this is the way I'm going it the way. This is my to remember by yourself. Stage 1 means math. Cancer is found only in the tissues of the cervix, microscopically or macroscopically. So, what is the meaning of micro and macro? Stage 1 means cancer is confined to the cervix only. This is strictly confined. It is not going outside the cervix. So A, stage A, what did son? In stage A, they divided it. The carcinoma can be seen by microscope. Only microscopically we can see. Okay, and 1A means stromal invasion less than 3 millimeter, and A2 means stromal invasion between 3 to 5. Okay, we done this A. If we will go B, B means invasion of the carcinoma confined to the uterine side. Still, it is in the to the cervix, but it is not gone to other parts. Still, it is in the cervix. But the problem is here, the one stage 1, it is microscope. We have to see by microscope. But in stage 2, it cancer become bigger. It is become up to 2 centimeter, between 2 to 4 centimeter. So what we are going to do? And stage 2, less than 2 centimeter. Okay, stage 1b1 means 2 centimeter, 1b2 means it is between 2 to 4, and stage 1b3 means it is more than 4 centimeter. Now our question is that she want the fertility. If she want the fertility, up to what stage we can do for her the fertility wish? What do you think, Dr. Ayad? What we will do here? Hmm? What's your opinion? Do you have any opinion, doctor? Dr. Ayad, can you listen? Can you hear me? Um,
Yes, yes, I'm hearing. Yes.
okay,
Okay,
so please tell
so
me
please
what
tell me
what you think
what you think
fertility up to what
fertility up
stage
to
will
what
do?
stage will
Sorry?
Fertility. She
do?
want the
Fertility. She want
fertility.
the fertility.
So what we will do?
So what we will do?
Fertility, you can do large loop oxygen. You can do cone oxygen.
Mm-hmm.
Uh-huh.
Then
Then
Uh,
okay, I will tell you. See, doctor, just remember one thing. Means, my friends, just remember one thing. When we are doing the cervical cancer, if she want the fertility, there is a certain stage we can do the fertility preservation. We cannot do more than that one. Beyond that one, we cannot do it. Okay. So what we will do here? Here it is microscopic. If it is a microscopic, okay, we have a best chance. She can have the fertility which we can make it there. Then we will go to stage B. Stage B is up to 2 to 4 centimeter. My brother, my friends, 2 to 4 centimeter means it's going to be a very big cancer. Stage 2 and stage 1b2 and stage 1b3, and 3 means more than 4 centimeter, and this is stage 1. Here up to 1b1 it is less than 2 centimeter. So how we are going to remember, because our brain is not so good that we have to remember step by step everything in the word. We have to remember by this thing, the stage classification, because this is very important for the exam point of view. How we will remember? We will remember that stage 1 is confined to the cervix, only the cervix strictly. A means divided. A means it is that this invasion is microscopically. B means macroscope. Macroscope we can see by our eyes. Okay, so if we are seeing by our eyes, so it means 2 to 4 centimeter is a big mass, big cancer on the cervix if it is happen. So we will leave it stage 2. Stage 2 is not off for us. Just remember that like this, because for the exam point of view I'm telling it. So B is not possible for us to go, because that cancer is 2 to 4 centimeter, and 3 means it's more than 4 centimeter. So what we are going to do? So we will leave all these things. So what we will do? We can say that this, if she want the fertility, we can do in a stage 1b1, up to 1b1 stage we can do for her the cancer is the treatment. So what will be the treatment? We have we have two things which we consider in our hand. One is the cone biopsy, one is the lids. Okay, cone biopsy when we are going to do and when we are going to do the lids. The cone biopsy is that if the this is a microscopic, so this is the best treatment for her the cone biopsy. Cone biopsy like a cone. We have to remove the cervix like a cone, but we have to consult to the patient that she is no contraindication for the pregnancy. She is supposed to have no contraindication for the pregnancy. Means like contraindication, uh, they'd say 25 years of age. We don't know that maybe she is having some medical problem. The best one contraindication is the pulmonary hypertension. Right now, I'm just talking about even 25. What is the problem? She cannot have it. She can have it. So we can give the answer that fertility wishes, we can take it at the stage and the grade of the cancer, and the patient wishes. Okay, so her wish is that she want the fertility. Okay, we understand she want the fertility. So up to what area we can do it? 1 to 1B1, because 1B1 less than 2 centimeter. After 2, 1B2 it is increasing 2 to 4 and more than 4 centimeters. So we leave that thing. So we will stick from here. So it is microscopic stage 1A. So we can do the cone biopsy. Now, if the area is increased, if it is not microscopic, it become macroscopic. We can see that cancer. So we have two options: cone biopsy or the lids. The thing is that cone biopsy we already have to done one, and when we are doing the cone biopsy the area has to be clear, margin has to become clear. But the problem is that we have to consult to the patient because she want the fertility, but we can tell her that if we will do for you the cone biopsy, you have a risk of preterm birth. So this is the risk she has having with this cone biopsy. Okay, now the cancer is bigger. He will tell you, okay, now the cancer is big. So what we have other option, cone biopsy is also there, but lids is the best option. Why? Because that area we have to take it, but how we are going to take it? Here the thing is that we have to look about the trachelectomy. Now we are going to do the lids and the trachelectomy. What is trachelectomy? Trachelectomy means we have to, trachelectomy is two types. Okay, simple trachelectomy and trachelectomy, radical trachelectomy. So this depends upon the size. If it is, we are doing it is, if it is a 1B1, okay, 1B1, because the cancer is still less than 2 centimeter. Here we can do the radical or the simple trachelectomy. This depends upon what? It depends upon if there is no invasion of the parametrial invasion. Sorry, the lymph invasion is not there. Okay, because beyond this stage 1A2, there it become macroscopic, so there will be a lymph invasion will be there. So here, if there is no lymphatic invasion, how we'll know that there is no lymphatic invasion? This is now the best treatment, the newer treatment which they are doing it. This is called the central lymph node. When they are doing the examination, at that time they will do the central lymph node screening, and if they found out there is no central lymph node involvement, they will not do the lymphadenectomy, anything. They will not do anything with this thing. Means lymph not involved. So she has a chance to do the radical trachelectomy. But if it is simple, there is nothing more than that, no sin as this one involve the lymph, then we will do the simple trachelectomy. Though, what is simple trachelectomy? We will remove the cervix of only the upper portion we will remove. We will not remove the fornices. But if involving the lymph nodes, then we have to remove the fornices. This is radical and simple, no need to do it. So this is our treatment finish about the fertility. Fertility is very important in the cervical. Why they want to ask it about that thing? It's clear, doctor? Any question?